Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome for our event tonight. And first of all, I would like to thank Istimaku and Jam'iyyat Ihar for this event. Our speaker for tonight, he's known for everybody, Professor Saeed Al-Ghamdi. He is a senior consultant at King Abdulaziz University Hospital and King Faisal Specialist Hospital. And he had many positions, including chairman, deputy director, regional manager, and he was also ex-president for the Arab Society of Nephrology and Transplant. So our topic for tonight about COVID-19 and nephrology patients. So we have a good group of patients from CKD to dialysis to transplant to patients who are taking immunosuppression, in particular the glomerulonephritis patients. So without further delay, Dr. Saeed will start, but for the question, we will leave it till the end. We will open the chat maybe around 30 minutes from now, and I will receive all the questions and I will address it at the end. Professor Saeed Al-Ghamdi, what do you for you?
Bismillah, alhamdulillah, wa salatu wassalam ala rasulillah. Thank you, my dear brother Muhammad. You see the presentation on the screen, huh? Do you see it?
Yes.
Okay. So the subject which has been asked to present today is about COVID-19, which is the subject of this particular moment. And as Dr. Fadl Ray said, that's probably we'll talk about it in whole nephrology, including dialysis, transplantations, and the effect of acute kidney injury with the COVID-19. If we okay. Do you see the slides living or no?
It's not moving.
نفس الشيء يعني not moving. Let me just get out of it maybe.
اضغط في نص الشاشة يا دكتور واعمل نيكست عادي.
Okay, done. Perfect. Perfect. We'll go again. Right. So we'll try to today. Actually, we go for the start our talk about this. One is about introduction about COVID-19, and what about COVID-19 in dialysis patients from preventive strategies, and we'll describe 3 outbreaks in dialysis unit, and how is it happening also somewhere else in the world. What about the status of COVID-19 in transplantation? And what about the current testing methodology we have for COVID-19? And lastly, we'll talk about what if the patient develop COVID-19 from general population, and does he develop renal abnormalities or not, and what kind of abnormalities they develop those patients. Before we conclude, we'll talk about some controversial issues in COVID-19. I must tell everybody here that this field is really evolving field, and if you ask anybody of us who's working with these patients who are having COVID-19 or dealing with dialysis patient, transplant patient, our position right now is something totally different from what's been going almost 6 weeks ago, because the field is really quite evolving, and our experience exponentially increasing. And most of the information we have right now, there is multiple, more than 100 publications in the field right now, which talks about this subject. But still, there is many of these information are got from website, because still did not pass through the peer review processes, and it's just shorter or brief communication. For this reason, actually, we expect that a few months from now, we'll see lots of information about this disease, which is going to be totally different, or sometimes might be different with what we thought about it. Everybody knows about this virus, and I must say that the virus actually, which make it distinct, is this spiky formation, which called the coronavirus. And this spike formation, which really makes it attachable to ACE2 receptors in the lungs and some other tissues. And that's what is quite essential for its sticking into the host cells and eventually producing the disease processes. And there is actually also membrane, an envelope there, and a nucleocapsid protein inside the nucleus. But all what you call actually has been termed as nuclear parts or nucleotide parts. The disease actually starts from infection period, which might last 1 or 2 days, then goes for incubation period, which may go up to 7 days. And then you have either the disease itself with a symptomatic or asymptomatic process there, where the patient can be shedding the virus during both stages, the pre-symptomatic and during symptomatic period. And here actually the majority of the patients are having mild disease processes, but it's certainly a severe form of disease which can occur about 20% of the population, of the COVID-19 population. They might have severe disease with some respiratory involvement. And at that stage, with variety of attacks by the virus to the lung tissues through the ACE2 receptor, it might produce what you call cytokine storm. And cytokine storm leads to, it's like an autoimmune processes, which involves various organs, not to underestimate any other organ, but certainly the lungs taking the major hit in these processes. The mortality of COVID-19 is probably in between the MERS-CoV, which we had in Saudi Arabia a few years ago, and the more like swine flu, which H1N1. These actually were the MERS-CoV at 35%, 1/3 of the patient they die. And COVID-19, it depends on the population study. If you go take it, for example, from China, around 3.9%, 3.6%. If you take it in America, it's about 1.5 to 2%. If you took it in Italy and Spain, other countries, it might go up as high as 8 to 10%. So it depends on what the population studied. This gives us what could be the cause for this diversity in mortality between different groups of nations. One of the theories is probably that due to that there is diversity in the genetic structure of the virus itself, and some novelty about from time to time about this virus was so the virus which is present in Italy or Spain might not be the same what we have in Saudi Arabia or the one we had in China. And second explanation, probably because in those countries they have what you call herd immunity, where they left it going without any specific matters in the beginning, which has led to that exhaustion of healthcare resources. And sometimes with the exhaustion, you might have a premature mortality for some patient who could be saved if the healthcare situation was robust or a better situation. So as we said, COVID mortality is about 2 to 8%, depends from country to country. And in Saudi Arabia, actually, is about 1.1%. It's an iceberg, which what you see the mortality is about on the top of it, but you have a quite significant number of the patient. They are asymptomatic, and at least 30% of the patients, some studies show about 70 to 80% of the patients that are actually asymptomatic and or mild case. So about 80% of the patient either mild cases or totally asymptomatic, and only 20% they manifest significant symptoms, which leads them to hospital, and 5% they will go to intensive care facility. And a symptom which has been described never changed, but we discovered that these symptoms are not the only one which you have to be worried about. Yes, certainly fever, dry cough, fatigue, which really outnumbers other symptoms. About the majority of the patients, they have these things, but also short of breath about 80%, myalgia, sore throat, and others, chills. But what these symptoms, which is really more suggestive of upper or lower respiratory tract involvement besides the fever, is very well known to everybody. But certainly there is atypical presentation. We have to be careful, and we have to be expecting it from time to time. For example, we have started to see more and more of cases of anosmia or loss of smell sensation. And this is really actually, I remember one of my patients and dialysis, she called me from one of the highly stricken area. She just told me that, doctor, I have just loss of sensation. And then I discovered that mother and sister are in ICU with COVID-19. So, and then she was tested and she was found to be positive also. So there is certainly actually anosmia or loss of sensation with loss of taste sometimes are one of the new things we tend to forget. Diarrhea actually, if you look at the Chinese experience, they talk about 3.7% of the patients have diarrhea, but more recent data from America show this one to be almost 1/3 of the case they have some form of diarrhea. Abdominal pain is something unheard of, but I can tell you at least 2 of my patients who is being later tested to be positive, they have just only abdominal pain as a primary complaint, so don't underestimate. Palpitation is strange because if you look at most of the report talking about patients they having shortness of breath with difficulty breathing and with bradycardia. But tachycardia, I remember palpitation, one of the patients, we thought that she is not yani, but eventually with palpitation, her main symptom with no fever, no other things, and then eventually found to have COVID-19. So this, the story of anosmia, which is really, but some other strange presentation, like blistering in the toes and some change, especially in young patients who have COVID-19, can be described, especially in Europe. As I said earlier, most of the symptoms of most of the bodies will be involved by the disease process, including the heart, which can cause significant heart failure, blood vessel to form major thrombosis in vein or artery. Kidneys certainly will talk about it. Brain, it might cause thrombosis and strokes. Lungs, we expect this one, and intestine also, where the patient will be present with diarrhea in about 20 to 30% of the cases. This actually the most recent by Walker et al. Were actually about to be published very soon, but this paper talk about in America, in the state, there's about 380 patients from 9 centers where GI symptoms present in 61% of the cases. These are quite significant number of the way they have some GI symptoms. They found anorexia in 35%, diarrhea in 34%. It's really quite common. Nausea 26%, and you found also anosmia or loss of smell with GI symptoms, more associated with GI symptoms. There was no difference in lab clinical deterioration, ICU admission, patients will have GI or have no GI symptoms, but certainly it's really quite interesting. As I said, large vessel strokes as presenting feature as published in New England Journal of Medicine. There is in COVID-19, there's actually 2 cases where they come young patient who has no tangible risk factor. They come with just only large vessel strokes and with being confirmed by CT scan. So this tells you that it's not the way we used to know that's upper respiratory infection or fever or just the lower respiratory, but SMAT comes with a variety of events. This infection is really could be mild, could be severe, and the severe, which is called on the right side, you could see it that where hyperinflammation, where there is release of lots of cytokine in circulation, and that's probably the cause of mortality. It's not the virus itself, but the storm caused by the virus. And this systemic inflammatory response syndrome might lead to shock and multi-organ failure. And what's called ARDS is not really 100% agreeable condition. Certainly, there is actually decreased oxygen saturation to even sometimes close to 0, but still does look probably in some of the comments does look exactly the same like what you see in RDS with the difficulty in inflating the lung and requiring high PEEP. But in majority of cases, on the left side, I see the virus start. It takes about a week for the virus to 3 to 7 days to reach the symptomatic phase, and only 20% of the patient might have go to pulmonary phase, and 5% they go into hyperinflammatory state or systemic inflammatory response or cytokine storm. From various data, disease, as I said, is mild. Only a small percent, 20%, they have actually severe disease, and less than 5% they have critical one. And the majority of the patients they have some comorbid conditions, especially cardiovascular disease, diabetes, coronary respiratory disease, and others. If you look at actually age is really very important in the causation of the disease, or actually associated with disease. You find much more as somebody who's very much older in population, about 15 to 18%. Actually, some of the Chinese studies show 18% of the patient above the age of 80, they of the cohort actually they are more than the 80 years of age, and becoming less with the younger age group. If you look at actually this, what we discussed earlier on, that the symptoms might be mild to more severe, and eventually the what you call the storm. And the storm, honestly, is really a very nasty process where the patient mortality might go, when he reaches storm, up to 70% of those patients might die, where they have lots of cytokines born into the circulations, causing a variety of things, including hypertension, multi-system organ failure, causing also respiratory distress, and variety of things. And that stage, actually, that's why which headed to several experts in the field to suggest to tackle this, what you call the cytokine suppressant medication to start with. And it was agreed with that steroid, 1 gram daily, might be one of the options. And certainly, even the Ministry of Health now here in Saudi Arabia has the doctor getting the tocilizumab anti-6 as part of the treatment for somebody who has reached intensive care unit and they require some high oxygen flow, require ventilator support. And those patients actually means that you are really taking right now not only the virus. The virus treatment is at the stage before that, including hydrochloroquine, ritonavir, levinavir, and remdesivir. Now right now for production right now the USA. All this is really antiviral. But we talk here actually when we talk about cytokine storm, we talk about tackling the hyperimmune response, or systemic inflammatory response, with giving more immunosuppression. And stressing this point because it brings it to the status of transplants, which we'll discuss it at later stage. The optimal disease management until now actually require, as I said, antiviral therapy in the early disease and advanced disease, and some medication to tackle the systemic inflammatory response syndrome. Okay, what about how this actually disease, how to treat it, what's the histology of the disease? But everybody knows that we have to, the most important one, because with the 3 million, more than 3 million patients in the world has been affected by the virus, and much more who's affected but not discovered. Let it bring us actually to the question, how the preventive strategy, especially certainly social distancing has been adopted and it's quite efficacious, and as we said, prevention better than cure. Okay, so I'm sure I will not go into this detail because everybody knows this detail, how to take care of from social distancing, avoiding touching surfaces, not touching mouth and nose and eyes, washing the hands and washing the hand and washing the hands. And then for somebody who's really suspected, has to be completely isolated, not only socially distanced, or what they call shielded out from the society. This shielding or social distancing, there is some studies being going right now, but honestly, upon the study which has been done on COVID, briefest form of corona, it wasn't shown that of clear evidence or high strong evidence, but certainly we are talking about something else. We're talking about disease which is highly contagious and striking everywhere. And that's probably, this information doesn't hold true. And that's why actually everybody is probably going with the social distancing and isolation for suspected cases, suspected asymptomatic cases, and admission to the hospital of symptomatic cases. If you look at the review from the United States of America, people are really at least 42% of the patients, they are improved their personal hygiene, like washing the hand frequently, avoid crowded area, refrain from touching objects in public, avoid physical contact with tourists and others. avoid consumption of raw and cooked meal, a variety of things. But interestingly, in South America, the 36% of the population don't believe any of that. So still, it means the disease will stay with us for some time. These preventive measures, certainly everybody talk about the curve and knows the curve. I won't talk about it because for even the general public, they know about the curve. I remember one of the people from my patient community, he called me talking about the R value, about the curve. So people, they know exactly what we are talking about. But certainly, when you do social distancing and the protective measure, probably you try to flatten the curve and save the healthcare resources. This has been found also in India, with a variety of measures has been taken. And in Saudi Arabia, honestly, we're doing quite well. And I'm really proud of what has been achieved so far and how the methodology has been done, our strict application of the system. And according to a statistician, they feel that probably by 19th of May, probably the disease will be half what we see right now. And we should expect right now, this particular day, that we should see the curve is coming down according to various statistical methods. And we probably look, if things goes very well, that 90% of the disease will be out by 11th of June. I'm not sure if they're really going to be there, or this actually just only statistical methodology, which is not in touch with reality. I have no idea. And probably those is really estimation. I wish it's really true, but I don't have any comment further. But certainly, I strongly believe in the measures being taken, and I think we should go for it until we see the curve coming down very significantly. We know that our patient populations, renal patients, they are really the worst actually of all, and that we think have to have actually better care for them and how to prevent this. I'll discuss about this this one because preventive strategy in dialysis is a really special subject and has to be taken very carefully. And I'm sure everyone working with the dialysis patient is quite paranoid about the situation, and they have to be, because otherwise we'll have actually outbreaks like what's happening everywhere in the world in dialysis. I remember there's several notes coming from India where there's outbreak in Venice, of course, and what happened in Italy and Spain and other countries in Belgium, other European countries, is really quite of expectation, similar to New York City and others, which make us actually should be very careful. And a word of thanks to MOH here by when the Central Dialysis Committee in Saudi Arabia, by their vigilance about looking into this issue very carefully and try to give it its utmost importance and try to force and push for stricter measures to prevent the disease to go into outbreaks into dialysis unit. And this by case definition before the arrival of the patient to the unit, and make very clear communication between patients and the unit just before they arrive. If they have any symptoms, which might suggest of COVID, they better not to show it to the unit, they better show it to the hospital, and so on. And secondly, the most important thing is the visual triage or respiratory triage, or these kind of terms. And actually, the MOH has made several forms with scores. Even, for example, if somebody was coming from highly endemic area about 4, and then given more something like fever 2, and then if you have more than 6, you have to probably show up to the hospital for further. This visual triage is very strict and actually is being much more than what you imagine, to the extent that most of the units right now, they keep the patient in their car and they give them number, and they triage them one by one to prevent overcrowding, and in order to allocate their spot, make sure that they are really free of disease and totally isolated and not to transmit the disease to the net. And this visual triage, as I said, is probably the most important. Mask is essential. This is really conflicting because it was an issue before saying that mask is essential only for symptomatic patient only, and not everybody, not patient. And days and nights has shown that surgical mask is probably essential for everybody, either patients or healthcare worker, both are right. BBE will leave it later on, discuss it. We'll discuss what about evidence we have right now. And then one of the areas to prevent preventive measure is just to have fixed staff patient assignment. So you have to make this particular name of staffs are assigned to this to particular patients. And fixed patient bed assignment also has to be there, bed and shift assignment. And actually, MOH has issued a decree which is quite strong that no patient transferred from unit to unit, and this actually in order to prevent. And from our experience from COVID MERS CoV, the previous one, it was really a disaster at that time because one patient can transmit the disease to other unit and make a hell of problems for all the staffs and everybody with high mortality and morbidity. So these actually the virtual triage system, which depends on making the questionnaire and then ask the patient about all the symptoms, make sure that what about his contact, variety of things, and then they take all the vital signs and make sure that the patient is very safe to go into the unit that they pass it through. Otherwise, they will just ship him to one of the emergency room which is assigned to that particular unit. So certainly this visual screening on triage is very essential to try to prevent patient from coming, but that's not rosy as we wish. The hemodialysis patient referral process is really quite simple by visual triage, where somebody who's really had nothing with low score, they go into the unit. Somebody who's exceeded the score of 6, they have to be transferred to one of the assigned hospital emergency room, where they have to be checked there and swab has to be taken and to be dialyzed there until he's very completely clear the 2 negative swab or 14 days has passed on this one. This actually the regulation and what you call COVID ready places, but that's the system and that's what happened. And if the patient have developed actually, somebody developed actually has a positive swab, they will go to the hospital until they have to negative swab. If have suspected, they have to make sure they examine, taking swab, and then either they keep them most of the time, which is called the system, should be kept in the hospital to be dialyzed there for 14 days, or sent. And if they sent to the hospital to the unit, it's a really quite risky process. So the process is, if the patient is really free, low score, go to dialysis unit. If they have higher score or suspicion of COVID infection 19, they will be going to the emergency room of any hospital around, and then at the emergency room they will admit when to prove whether it's really negative or positive and dialyze there until they have negative, and then they can be returned back after 14 days to the dialysis unit. That's actually the fact. We know all our issues. Certainly, we will have to protect our patient from COVID-19, but certainly the healthcare worker is targeted. If we look at what happened in European countries and other areas in India, there is a major issue with the outbreaks into the unit, and many of the units has lost its manpower or which can run them. So mostly, we are really concerned about both the patients and the healthcare worker. We know that there's one experiment for Solano County, California, a recent publication about the transmission of COVID-19 to healthcare personnel. They looked into highly qualified healthcare personnel, and they observed the infection. They did serial measurements for PCR, and to their surprise, that they found that at least after studying overall, that significant number of those patients, they got a transmission of the virus between them, and mostly happened in registered nurses, about 51% of the nurses, and some other healthcare workers have been affected in this one. So we will not talk about it's a joke. No, it's really a true story. If you don't imply strong rules and regulations regarding protecting your staff, then you'll end up 50% of your staffs are infected, and that's what happened in India and other areas. Now, how we can reduce the transmission? Certainly, we have just by, as we mentioned earlier on, by educating the patient about a variety of things about the disease, about how to prevent it, how all the measures, and also by applying some strong measures inside the unit in terms of the visual triage, and then also the staff, how to protect the staff. whether you talk about PPE or various issues. This has been a subject of controversy, whether just only surgical mask is enough with the regular precautionary measures, or should be more has to be done. We'll discuss them. Surgical masks are honestly, there is a conflicting message. It was from the beginning until now. Nobody to be blamed for this one. We can even look at President Trump in the beginning. He wasn't really sure it's really of value, but later on that everybody should have even make clothes as a mask in order to prevent this. And right now you find everybody will have most of the people they have masks on top of them. And certainly the mask may protect. It's not that it's been said previously, because can prevent the infection from that person and protect me as a bypasser or somebody who's there. But not be 100% protection, but at least some sort of protection. Ministry of Health here made its guidelines here, where actually anybody who's really working with COVID possible COVID case or diagnosed, they have to have actually full PPE, including goggles for the eyes, gloves, variety of things in order. And these actually for patients who are really dealing with like in outpatient department, like in our dialysis unit and others, they have to be PPEs as they are dealing with suspected cases. That's actually the regulation. And if you look, even the international regulation goes in the same line as same this one. But what you call N95 mask is not to be used except for somebody who's working with aerosol, somebody intubation, taking a swab, other things they might do N95 for medical personnel. But in general, the PPE is right now standard of care for all suspected cases of COVID. Nobody will argue about this one. But the question, how about if there is a risk of infection there? Is it justifiable to give it to everybody? Or I know the demand is high and the supply share is probably in limbo right now in some countries, that which led to various recommendations. But certainly the N95 mask is really meant actually to protect against not only droplet infection. For surgical mask, we use it actually for mostly the droplet, like not airborne. The airborne is mostly for N95 mask. There is studies has shown to ensure that the line is going towards that value of N95 mask in preventing infection transmission of laboratory-confirmed viral respiratory tract infection. So certainly it's better, honestly, if you apply N95. But this one is really quite expensive and unavailable and have a certain problem. I will see from the recommendation of the American Infectious Disease Society of America, you find that they are not stressing on getting N95 to everybody. It's for a particular group of patients. So it's really it's much better than surgical mask for sure. Lacking because of availability, probably not everybody should be wearing it. This actually the recommendation of Infectious Disease Society of America, where they said if the patient really having actually what you call risk of exposure to aerosol, then they have to go for N95. But they have no aerosol generating procedure like the aerosol, like variety, including a ventilator, BiPAP, and others. All these actually, when you are the patient are expected to develop infection there, then N95 is a must there. But if not, they will go for masking, regular surgical masking. And this is really manifests itself in the recommendation here that surgical mask probably is more work, but 95 if there is aerosol exposure. And they say that probably you can reprocess N95 instead of going with surgical mask for somebody with high risk of development of airborne infection. This actually we'll discuss later on whether COVID-19 is purely droplet infection or there is maybe a possibility of airborne infection. So what about the COVID-19 dialysis unit? If you look at it, for example, here that in Europe, for example, they have looked at this about more than 2,700 patients with COVID-19 positive. They are dialysis patients. and 1,200 they received hospital-based care, and outpatient 928, but most of them actually from outpatient care. But home dialysis was also 86 cases. So even at home dialysis, you still might develop COVID-19. So these actually 2,700 plus patients who develop COVID-19 in dialysis population in Europe, they have actually 300 deaths, which about 11% of that cohort. So it's really slightly higher than what we have there in Europe for mortality, and certainly very high for us and for the rest of the world, because the mortality, I said, in Saudi Arabia is just about 2%, and similar to 1 to 2%, even 1.1% Saudi Arabia. America is about 2%, and Europe they might go up to 8%, various European country. But here is about 11% mortality in the stage-in disease. This, what we learned from Milan experience has shown that their hemodialysis unit has been badly stricken below the virus, and left to the question, what else can be done? And because that patient should wear a mask, irrespective if they are symptomatic or not symptomatic, and PPE probably should be considered for all healthcare provider, because otherwise that you will have actually problem with getting infected. I'll give you 3 examples of outbreak or infection which has happened in Saudi Arabia. I will not mention where or where, but certainly just the reason for that one is the lesson we can learn from this outbreak. This actually is the most interesting first outbreak in a unit in highly locked area. It means an area like, for example, where there is the government has have no movement and 24-hour curfew. In those area, there is actually that dialysis unit. There was 11 patients asymptomatic, but from the same area, and the rest they are from not locked area, but city was endemic for the virus. So that actually particular unit, they have only 11 patients asymptomatic. So they decided, how about if we go and screen them on antibody screen, IgG and IgM, just routinely without symptoms. And they eventually discovered that 2 of their patients, they are IgM and IgG positive, eventually has proven to be COVID-19 by PCR. So even asymptomatic patient, they can. So it's okay. Well, this is actually positive cases by PCR, but our staff is fine. But 2 days later, one of the nurses is still sick, and eventually we came to recognize that still that particular nurse was taking care of that particular patient, and he got infected. So you got somebody who's totally asymptomatic from high endemic area, came to your unit, passed through the triage system, was absolutely fine, and eventually he's infecting your staff. That was actually led by heroic measures inside the unit in terms of changing the staff, changing everything, and with lots of unfortunately, all the staff, all the other staff in the unit, and all the patients, they have not been affected by the virus, except that particular nurse. So that's the first case scenario. The second case scenario, so what we learned from the first one, that asymptomatic patients still can transmit the infection to you, especially in high endemic area. Second report thinks that the index test was a 50-year-old patient picked up at visual triage with fever and cough, which is easy. So they said, okay, you have, they have all strict possible, strict triage, visual triage. That particular patient, fever and cough, has been taken to the hospital. So the hospital we admitted there, swab was taken, but was negative. So they, after 10 days from that isolation, they decided to send him up to his primary unit. So as 10 days is really enough to take the patient back after 1 or 2 swabs negative, and just only short breath, fever and cough only. That's the question. When he was sent 10 days after that, he was integrated to the dialysis because he was negative, and he was in the unit for 2 days or 3 days later. He developed fever before he comes to the unit. And that was weakened, and he was readmitted again and found to have positive swab. During that period of time when he came, few days, so a week later, from that particular incident. 12 patients were identified to have COVID in that unit. 6 were symptomatic and 6 was asymptomatic. And there was actually 2 mortality from that particular source. So it's really quite a serious incident. It's quite a serious issues here. And the message we should get from here that probably you don't really have to respect only 2 negative swab. Probably you have to respect also the duration, because the sensitivity of nasopharyngeal swabbing depends on the technique of taking it and various other laboratory measures. And negative swab doesn't mean patient doesn't have COVID. And that's what happened actually when we discharged from the hospital 10 days, came back to the unit, and probably probably he spread the infection to other 12 patients. And so I forgot to say 6 other staff. Alhamdulillah, all the staff was perfect. None of them required hospitalization. They are doing very well. One of them was about a little bit sick, but eventually went well. And all the staff was fine. And all the patients in the unit has been screened. 12 patients, only of them. 6 they were symptomatic and 6 were asymptomatic. If you look at this here, actually here in case number 1, here's the patient. Looks how far from the patient. Look, the blue is a case which is asymptomatic, and red means symptomatic cases, but spreading everywhere, and most likely because the nurses who got actually involved with transfer the virus from here to there. And look at here, between patient, this one, the one beside him is asymptomatic with the virus, the one behind him too, and here the asymptomatic cases, and here 2 cases beside each other. One of them who got very sick and went to the hospital and went to the ICU. So certainly, actually, it's a serious matter. And what I'm trying to suggest in this one, that no patient has to be allowed to go to the unit before at least 14 days from hospitalization for the last symptoms. That's my suggestion. And so, as I said, point of entry, this one was discharged patient from hospital and was affected staff and patient. The outbreak number 3 is very interesting. It's not an outbreak. It's just a simple one, but it also teaches me a lesson here. This is actually a 50-year-old female patient, long-standing diabetes with all of the complications. She presented to the unit almost 10 days or 22 weeks earlier, 10 days earlier, with a blocked AV fistula. They put for her the femoral line, and there was one nurse taking care of her at that time. And after that, 10 days later, the patient came again to the unit with fever this time, and she had very classic diabetic food, which you can not miss it. So the decision was, well, we will dialyze her, and under strict conditions, and we try to, but during the blood pressure started to drop down, so they terminated dialysis, shipped her to the hospital, and that hospital was checked for that she's COVID-19 positive. The question right now, she presented like diabetic food with everything, but later on turned to be that she's also harbored COVID-19. And unfortunately, she infected, transmitted the infection to that particular nurse who was taking care of her. But she's alhamdulillah fine, there is no other problem. So, so this actually, even some patient, they can go for visual triage, and we conclude from this, we listen from this outbreak, 3, visual triage is essential to prevent transmitting infection to the patient and staff, but asymptomatic and pre-symptomatic cases may go through triage unnoticed. And suspected cases and treated cases is a risk for the unit, even suspected case, and should be dialyzed under special precautions. And the precaution usually they have to be dialyzed in a separate room if they get taken back, an isolation room, preferably hemofilter is there, and there has to be followed by disinfection of that particular space. Finally, COVID-19 might disguise itself with other infection like diabetic foot. So during this, what you call stormy cases of COVID-19, I think every single patient who's coming with it, you have to consider COVID-19 before you consider other possibilities. This study in the University of Medicine has looked into the pre-symptomatic SARS, COVID-19, and the transmission in skilled nursing facility. We looked into skilled nursing facility, and they found that significant number of those nurses, they got the infection, and they have said widespread transmission of SARS in skilled nursing facility is possible, and that's why a measure has to be taken to protect your staff. And how protection is there, and that's my belief, we should be actually, our staff is taking care of possible COVID cases, or an area where highly endemic with the disease should be like this, where the staff should be wearing PPE, including the goggles and other things, and should be treating patients as possible infectious to them. And every patient is there, not only for patients who are being tested and found to be positive. We finish from dialysis, we'll go for transplantation. And at transplantation, I have in this here my friend and colleague, Dr. Adel Tayyar, rahmatullah alayh. He was the first transplant surgeon dies at the front line in the UK. Adel Tayyar, many of you know him. He was working with us as transplant surgeon, even working in King Faisal Specialty Hospital as transplant surgeon for local position at that time. And actually, we miss him dearly. But he's one of the physicians who died in UK with COVID-19. So the transplant, the most important thing for kidney transplant recipient is education of the patient, how to protect themselves, and when to report to doctor or emergency room for a variety of things. And they have to be learned or taught carefully about all the techniques to prevent the infection in terms of a variety of things like social distancing and many other which has been described earlier on. The question that, this actually, we don't know exactly until recently that we expected that patients who have been transplanted, they are immunosuppressed, they are at high risk of developing COVID-19, and might they have more mortality, similar to what we see with the viral illness when we have somebody who's on TAC and mycophenolate mofetil. So these actually, the Scott recommendation is really quite neat. They they advise to postpone any living-related transplantation except for very selected cases. And the only working right now is a deceased donor program is operational, but unfortunately there is no donor because everybody is sitting at home, no road traffic accident, no accident, there is no machinery, there is no workers in place, so everybody is sitting at home, which has led to the disappearance of potential donors. If you found, for example, this is a donor, they have to have 2 negative swabs. That's the regulation from Scott. For recipient, there is nothing there except strict precautionary measures, including education. And there is no suggestion of reduction of immunosuppression until this point in time. Some did, the authority suggested reducing immunosuppression, but honestly, it was not. And but they should be considered as vulnerable group. And this actually, the first one, Banerjee study in Kidney International, where actually looked at some cases with COVID-19. It's about 7 cases, and how they presented, and all the patients were similar to the rest of general population with symptoms. And most patients were in supportive care, reducing immunosuppression. Whenever they can, they just try to stop what you call MMF, or reduce immunosuppression. There's 4 patients from those cohort, 6 patients required ICU admission. 1 of them has died with pulmonary adenosuspected stress syndrome. So it looks like from this small cohort, the disease is really nasty one with transplantation. I'll bring you the Spanish registry of COVID-19, which is recently been published in Nephrology, April this one. They have reported from Spain about 668 patients on renal replacement therapy with COVID-19 infection. They found that the symptoms and presentation are similar to general population. They don't have any suspicion, but they found that high percentage of them require hospital admission, whether this due to the severity of the case or probably the fear of the treating physician. So 85%, but 8%, not 4 or 5%, required ICU admission. And the outcome was really worse than general population. There is 23% mortality, and the mortality is much higher, especially if you are on dialysis more than transplantation, and if you have a pneumonia. There is actually another study from a state about a small cohort, about 10 patients started sports transplant. 9 of them required admission, and median time for transplantation is about 6 years. And they found 60% they are male and 30% they are black and others. Presentation similar to the transplant, same like the Spanish experience, but pneumonia is really quite common. 6 out of 9 they have developed pneumonia. All of them they have their antimetabolite agents being stopped, like other, but they found the mortality is much higher even than the cohort of Spanish, which is about 30%. So probably, if I may say that transplant patient, when they get the infection, probably it hits really bad, and probably it carries higher morbidity and mortality. What about antibody testing? Antibody testing or rapid testing has been actually advertised recently with the appearance of Mr. Trump. There is actually, if you look at actually the blue one, it's the PCR, where it can be positive from day 1 and can stay until 29 days from the infection. So it's really actually because in the beginning it's the virus, and then the particle of the virus will begin positivity. But certainly it can go up to 29 days. If you look at the IgG and IgM from this particular test, IgG becomes positive in 7 days, and IgM about 7 days. IgM start from 7 days to 21 days. Then IgG starts from 14 days and continue thereafter. So the value of this one is really quite questionable, although it has high sensitivity of 90% at least, and high specificity from 90 to 100%. So it's really quite sensitive, but unfortunately cannot be taken as a gold standard test. Still, we do the nasopharyngeal swab with PCR RNA is more indicative of the disease processes than this one, because here you could have actually somebody who had the disease and recovered right now in the convalescence period, or somebody with the IgM positive still have the disease. And secondly, that the antibodies start right after 7 days. So you cannot use it actually with high definitive value to diagnose COVID-19. That's why the Ministry of Health probably discouraging from using it as a way of diagnosing the COVID-19. Okay. But if you look actually, swabs also is not perfect, despite we consider it as a gold standard, because it carries 70% sensitivity, and it depends on the technique of the collection of the sample, and of course high specificity, but there is false negative and sometimes false positive result might occur from the particle of the virus. Now we'll discuss about the AKI in COVID. Let's actually finish discussing the dialysis and transplant population. We will come to a general population develop COVID-19, and they have to be in the 5% of the patient who are being into ICU, or 20% who require admission to the hospital. Those patients, they are really at the risk of developing acute kidney injury from COVID-19. And if you look at the NACA study, Kidney International, the first one, which has shown that fever is really quite common if you have kidney involvement, cough, myalgia, fatigue, and leukopenia, lymphopenia. And those patients actually, eventually they will develop variety of things, and most importantly, some particular indicators of kidney disease. There is 50% of them they have rise of creatinine, and 14 to 27% rise in BUN, probably due to dehydration, and almost 44 to 2/3 of the patients they have proteinuria, and 26% they will have hematuria. So AKI is quite noticeable there in our patients who are affected by COVID-19 and require admission to the hospital. But at the same time, some other things like proteinuria, hematuria might occur. And the explanation for this one, 15% fetal creatinine, look at it's a septic process or systemic inflammatory response syndrome with cytokine storm, might be as affecting the lung, affecting the kidney and other, or maybe the direct cellular injury by the virus itself, and this not to be ignored, because sometimes the virus, variety of virus other than COVID-19, can affect the kidney, and has been proven even the previous outbreak of MERS-CoV and in even H1N1 infection. So certainly all these kind of effects, and COVID-19 is not exception, to produce 15% of AKI in those case-based population and 44 to 63% proteinuria, 26 hematuria. That's actually the whole things about it. But if you look at the biopsy has been taken actually, and they found that light microscopy that they might have a variety of changes, mostly affecting epithelial, tubular epithelial cells, podocyte, and marked tubular injury like ATN. And the ATN probably directly to the viral process invasion itself, or maybe also due to the systemic inflammatory response with the cytokine storm syndrome. So these, when you take biopsy, it looks like ATN. Other words, process is not ATN, but it's really tubular injury, I'd rather say. But also glomerulonephritis has been described with the COVID-19, especially IgA nephropathy and collapsing focal segmental glomerulosclerosis. This has been described. And collapsing focal segmental glomerulosclerosis has been described with HIV and also with a variety of viral infection previously. So this actually COVID-19 has been added to the list right now. So either in the majority of the cases involve AKI due to probably what looks like acute tubular necrosis and tubular injury, or they develop actually some glomerular disease in the form of IgA nephropathy and collapsing focal segmental glomerulosclerosis. Finally, we'll talk about the controversial aspect of COVID-19, whether this is airborne or purely droplet infection, and whether should we use mask or PPE. Thirdly, we'll talk about ACE inhibitors in patients susceptible to COVID-19. So is a droplet actually when you're about 1.5 meters from your sneezing or coughing or talking, but if you are having airborne, they might spread much longer, up to 12 meters, and this actually kind of stays hanging in the ceiling and everywhere above the head level for quite some time. Maybe it has been described in 21 hours. But this one actually is not being proved in all studies, but certainly there's many studies that are going on to prove that probably there might be some elements of airborne infection with COVID-19. And one of these studies being done with the recent COVID, they look into actually the epidemiological break in bus, this one, and they found that a significant number of the patients they got infected to reach the conclusion that probably it might be airborne. But really the argument is really not very strong. It could be also a droplet infection. Finally, we'll talk about renin-angiotensin-aldosterone system blocker, like an ACE inhibitor and ARBs, and the risk of COVID-19. There is some support, they say because it's attacking actually ACE2, and there's some here and there, it might actually make patients are more susceptible. Although it didn't make sense to me in the beginning, but some of the preliminary studies show that more cases actually are present in patients who are taking ACE and ARB with the COVID-19. But they forget that the comorbid risk profile is much higher in patients with the COVID-19. That's why, for example, you get mostly the cardiovascular disease and those patients that are taking actually ACE and ARB doesn't make them actually more susceptible. Until this paper came from New England Journal of Medicine by Tensy from Italy, and they looked actually patients who are taking ACE and they're taking ARB and they're taking diuretics, beta blockers, and calcium channel blocker. And what they found, honestly, that ACE and ARB patients, they are having less infection than others when they have COVID. But did not reach statistical significance, but they said probably it's probably the same. And it's really quite safe to use ACE and ARB in those patients similar to others. Until recently, another study in Chinese just recently published in Circulation, they found that 1,100 patients who are hypertensive and they have COVID disease, COVID-19, were admitted to the hospital, and they found that 188 from them, they are on ACE and ARB, and 940, they are on none. But when they look at the outcome, they found that patients taking ACE and ARB associated with lower all-cause mortality. So if not actually protective, it's the same. So probably you shouldn't worry much about ACE and ARB, and patients should continue their medication as is before. So finally, I would look at this picture, which really inspires me. I wish to see my unit like this in order to preserve my nurses and my medical staff. And probably that's probably the way it should be done. I should treat everybody in this particular difficult time as possible COVID-19. And eventually, I have to conclude with the saying that COVID-19 is highly contagious and a true killer, especially for older patients with comorbid condition. And I believe strongly that precautionary measures, social distancing, self-isolation, respiratory etiquette, and masking may prevent the spread of infection. And as I said earlier on, visual triage is very essential to prevent COVID-19, but in high endemic area is not enough. And probably asymptomatic cases, as I've shown you earlier, might get entrance to those units. And as has been shown, the discussion, infection easily transmitted from asymptomatic and pre-symptomatic patient. And for dialysis to treat, I think the best strategy is to treat all patients as possible COVID in order to prevent outbreaks and to preserve your staff. Probably all healthcare workers should wear PPE in order to protect themselves and our patient. And I've shown you that patients with renal replacement therapy have higher morbidity and mortality when they get infected with COVID-19. That's all, and stay safe. Thank you very much.
Thank you, Professor Saeed Al-Ghamdi, and we will open the floor for questions. But before we receive a question, I have, I think, 2 or 3 questions I received. I will tell you. So just recently, you know, and C. Jason, I think from Columbia University, they put, you know, some local guidelines they use in management of patients with a glomerular disease regarding the reduction of immunosuppression. I'm not sure if you are aware about it or not. So the question that for all these patients on immunosuppression, as example, patients with lupus nephritis, do you agree with the reduction of the immunosuppression?
Well, I don't agree for reduction of immunosuppression because actually for those particular patient population, I think the best thing for them is what I described, the precautionary measures and preventive measures, which is isolation and various other techniques which has been shown to everyone that is really quite efficacious. Reducing immunosuppression might lead to a flare of disease, and I describe the Colombian study, and I can show you also the other study has been done on patients who are taking actually taking what you call the hydroxychloroquine. They found that, for example, is not different from the rest of the not taking. Of course, this does not make any clear judgment, and we wait until we see further results, studies which are quite powerful and based. But for the meantime, probably same like transplantation, probably keep everybody on their medication, but strict application of precautionary measures, especially social distancing and hand cleaning. With mask.
So the take-home message that, you know, patients on immunosuppression for the time being, unless they have the disease, there is no need to reduce the immunosuppression.
That's right. Yeah. Okay,
I will have one question here. I think a question regarding the transplant. I think I have one question that, you know, asking that patients, you know, on dialysis for the time being get infected and they are at risk, and he thinks that, you know, transplant is the best option. So we have to advocate for transplant as the best mode for renal replacement therapy.
I did not understand
the question, but I think you know.
For sure, certainly, nobody will argue that renal transplant is the best possible option for any end-stage disease. But I must say, despite I show bad data or bad outcome with transplantation, I think right now preventive strategy is better than anything else, and I think we should actually stay away from transplantation at this particular time. Even it's the best option we have right now, and we have to resort to dialysis for the meantime, unless somebody who's really, for example, have no access or this sort of condition, you might consider transplantation because actually lack of data. just wait for a couple of months, and you'll see lots of publication and data coming on, because right now it's coming tens per day, studies right now. So it's really quite we are learning a lot, and until this particular moment, I would say don't do transplantations for this particular time unless really indicated. And if the patient is already transplanted, keep them in their medication, do nothing. Okay. If they are admitted to the hospital, of course, the hospital staff, they will take care, especially stop anti-metabolite, then they will keep the others. But let me remind you of something. During the cytokine storm, we give steroid 1 gram. We give tocilizumab, anti-interleukin. Okay, and there is a study going in small Simulect and other anti-IL-2
Basiliximab.
So it means that actually we are already trying to target them. What about tacrolimus? They are anti-interleukin 2. So the same line actually. So you could argue here and there, but the best strategy, honestly, keep the patient their medication, stay away from any unnecessary transplantation at this particular time until we have probably 2 to 3 months, probably the picture will become much more clear.
Another question, there is one question regarding the management of patients with COVID in ICU regarding the anticoagulation. So what you are thinking about citrate versus heparin anticoagulation for these patients?
We know that these patients are hypercoagulable. I did not, so there is one study has shown beyond doubt that the COVID-19 patients, they are hypercoagulable, not consumptive, but truly hypercoagulable. And those patients actually, that's why actually all the units right now, intensive care facility, they give regularly low molecular weight heparin for all patients. And because there is more pulmonary embolism, more DVT, more arterial thrombosis, so I'm sure heparin is really essential. Regarding use citrate or heparin, I don't see any for example, logic behind this, honestly. For heparin is really working beautiful, is available. Citrate requires lots of hustle, and it's not this difficult time. We have to go for citrate because you have to measure everything to make sure the citrate is really working fine for that patient. So honestly, I rather just keep it from heparin unless we see some data which is really supports citrate versus other. I'll go for that option.
During this crisis, we saw one of the advantage of the home dialysis, especially peritoneal dialysis, that we have for the time being, that especially with the telemonitoring, that we are managing them at home. But recently, from the European experience, we are seeing a lot of urgent to start PD. That means they are starting PD for somebody with acute kidney injury, as well as patient with end stage. They don't start them on hemodialysis because of the crisis. Your opinion in that regard?
We have talked about two different issues. Crisis, there is actually even for recommendation, American recommendation, look at the crisis about supply issue, supply chain issue. That's a different story, and I wish Saudi Arabia would look more to that direction. But let's talk about preventive strategy. Do you think, for example, in-center dialysis is really worse than home dialysis? The current recommendation says yes, that the inpatient dialysis is probably better than in-center hemodialysis. Like I have showed you some data from Spanish, that 83% patients actually, they are on home dialysis, they got COVID-19. I think COVID-19 can get you from anywhere, honestly. It's not only dialysis. And probably, that's not the risk there, especially if the precaution was not undertaken as like strict triage and PPE to everybody, okay, then you might be at risk. Like, honestly, you can get the infection by going to the corner store and buy something from there. So at this time, probably the system of home dialysis here in Saudi Arabia is doing well, honestly. But I will not suggest that patient to be transferred from in-center to, because there is no strong data to support it. And I think probably is much safer at the hand of well-qualified staff at this particular time.
More question. I think we are getting one question because it was written twice, so I have to read it for you. So one patient who was diagnosed to have COVID-19, and patient was hospitalized, but the family, they are asking to transfer him, to another city. He's asking about the opinion.
I will talk. The Ministry of Health is preventing such strategy right now. And I think they are right, because honestly, the moment you do the quarantine in every particular city, and this is a call of الرسول صلى الله عليه وسلم إذا دخل الطاعون في بلد فادخلوها وإذا لا تخرجوا منها. This is the best strategy, honestly. And you have to stop moving patient, but eventually they will move, because we start to see patient right now suddenly at the doorstep of the unit from other city, almost 1,000 kilometers away, asking for dialysis there. This actually issue has to be solved by MOH. Right now, the system and the regulation says that no patients allowed to move from unit to unit.
We have a question from Dr. Dildar. So,
and just one thing, and in my opinion, that if that patient, for example, the MOH decided that to allow it, okay, then I think we have to treat those patients as a risk, and to take some extra precautionary measures. Yes.
Sorry for that. So this question from Dr. Dildar. So the question said, what's your take on home hemodialysis post-COVID era? Are you going to see more home hemodialysis after this crisis ended?
If you want my opinion, I don't want to make my colleagues really dissatisfied with my argument. But I don't believe that home dialysis delivers the same dose of dialysis adequacy like the in-center dialysis. And certainly it's really good, and I still have my old notion. Everybody in the field knows me. I haven't changed my idea, saying that in-center home dialysis should be left for somebody who's difficult to move to dialysis unit, and for logistic reason, probably home is better for them. It's not for all, it's just for a very small minority of the patient, and I cannot ask to move from. Yes, it's very essential. I love it. I recommended that from the beginning, almost 12 years ago before coming, but I said it has to be for a small percentage of the patients who require that without any question. Thank you.
So do you think that, let us say that after 1 year or 2 years from now, that you will see more home hemodialysis? BD, I think that many people now, what we see, they are asking now to be transferred to BD when they especially during the care flow.
And everybody has heard me talking about BD first from almost 15 years and onward. I still hold to that point that if the patient wants to start dialysis, BD first is the best, for a reason known to every one of you. لكن staying inside home hemodialysis, I have some concern about it. And I say it's good, but for small percentage of the patient.
Another question, I think they are asking a lot about the critical care nephrology. So this question about patients, with AKI in the ICU with COVID, asking about the best modality, especially, considering, the cytokine storm. So do you think that CVVH is better than the CVVHD?
Well, logically, first of all, those patients are, some of them are very sick, okay, and they require some what you call cardiothoracic support, like a variety of like norepinephrine and others. And so they have also cytokine storm, and there is some studies in the past about the value of CVHD, okay, of removal of these cytokines and others. So logically, if you ask me, I say, and also for infection control variables, I'll go for CRRT more than hemodialysis in somebody who's in intensive care facility. That's my belief. It could be changed as like anything else with the coming days with the plethora of publications which is coming right now. But for the meantime, right now, it's holding true that probably CRRT is better in ICU than hemodialysis.
That's a question from me. So what do you think now for the time being? Because as you mentioned that one of our aim is to
So in ICU, many people, they adapt high volume for short period of time. Let us say that CRRT, high volume, effluent dose around 50 milligram kg per hour for 10 hours, just to minimize the exposure of the dialysis nurse, either the nurse in the ICU or the hemodialysis for patients with acute kidney injury and COVID-19.
Well, I look at the same principle, honestly. As I said earlier, I have nothing more to add here. If you ask about actually the time of the exposure to the CRRT, of course, the longer is the better. And as you know, there is usually one necessary concern for taking care of the CRRT itself, and sometimes becoming difficult logistically within a particular dialysis, particular intensive care facility. If you look at previous study, it has shown that intermittent is as good as CRRT in outcome. There's no difference. Even the story of cytokine removal, it has been shown that yes, certainly it removes cytokine, but does not influence the outcome. So if we look at we look about science. I love the science. So ask me, okay, I like CRRT here, but do you have any evidence that's really better? I say no. Okay, so still intermittent dialysis then. But if you have somebody who's really hemodynamically unstable, then you have no other option just to go for CRRT.
This question I think is very interesting. Any data about transmission of infection through the machine? Did you hear the question, Dr. Saeed?
Repeat the question.
I have a question from Ahmed Hassan asking that, about Nihal. Any data about transmission of the infection through the machine, through the dialysis machine?
Oh, no. Well, services, yes, for sure. Services is there. It's a service. That's one of the recommendations that every day after the shift, we have to clean the services, for sure. And there is no question. Even if you are actually in somebody suspected, you might do a fumigation too. So if you ask about service, I say absolutely yes. If you ask about the system itself, I say no. Because it's a closed circuit.
This question, this one by Ahmed Hassan. Do we need to screen all the dialysis staff and patients?
This is a controversial aspect. MOH is against doing this one, and they have to go for case tracing. If they have any contact with the case, they will do it. But routine is no. That's actually the position of Ministry of Health right now, which we follow utterly. If you ask me what about antibody testing, okay, antibody testing, well, I think is not completely void, or somebody consider, for example, I said MOH is not recommending it. No, it's useful, and I think it's useful to know the state of, if you may allow me, immunity inside your unit. But it's not good to trace cases. It's good actually just to study the status of about how immune is the unit, for example, 3-4 months from now. I think this is really also debatable. For the meantime, still antibody testing is probably is valuable, but is not probably cannot replace swabbing.
I think we are getting more questions. So one question is not difficult, but somebody asked, so we have to answer it. So do we need to insert dialysis catheter for acute dialysis in negative pressure room or a regular room? And to complete the question, asking which one is better, to minimize the exposure, IJ or femoral?
So if you talk about droplet infection, you don't need negative pressure room, or you don't need hepatitis. If you talk about airborne, certainly you do. Okay, and still the verdict is out. Nobody can tell you with certainty that this is 100% droplet, and nobody will say that even 10% not to be 10% airborne. So we don't know exactly. So for the meantime, the current recommendations as follows. If you're dealing with somebody who is proven COVID or suspected COVID, probably you have to have actually isolation, okay? And especially when there is actually dealing with respiratory secretion or aerosol, certainly you have to have a filter or negative pressure room, and you have to make sure about it. And even the staff, they have to wear a 95 mask, not the surgical mask. So this is actually the recommendation if you are dealing with somebody who is really having, especially producing aerosol, like somebody ventilated, coughing badly with sputum, or somebody requiring NG suctioning or something like this one. No. What we see in our dialysis unit, probably they are healthy patients with suspected cases. They are not asymptomatic, but if they are symptomatic, they will be in hospital. Asymptomatic. I think the safest thing is to keep him a filter at that particular place. That's safest. But it's not the recommendation right now, and very difficult to recommend it without hard evidence. But for the meantime, probably many of the dialysis units start thinking that way of keeping actually a filter for somebody who is really a suspected case, okay, of COVID-19. Regarding lines, I don't see it actually as a risk from aerosol inhalation or anything. I think goggle is really essential. I think PPE is really essential, and that's all what you need.
This question from Baha. If a patient is known to be on immunosuppressant drug like lupus nephritis, on hemodialysis, tested positive for COVID but no symptom, should we isolate her, and recommendation?
Of course, if she's positive, she'll be isolated, no question. And even dialysis should be in hospital, be hospitalized, because that's the system in MH. If you have somebody dialysis patient and who's been diagnosed as COVID-19, he should be hospitalized and dialyzed until they are negative for 2 consecutive swabs. And that's actually the system and the regulation. If you ask about the immunosuppression, honestly, you have to play it smart. I think, is it needed? First question, ask yourself. If it's needed, keep it. If somebody was really in flare, keep it. Okay. If somebody is really in a dire situation and have pulmonary involvement, no, I'll start reducing, at least stopping an MMF. The question right now, how do you reconcile that with giving, for example, steroid 1 gram and tocilizumab and others? As I said earlier, it's really controversial subject. But for the meantime, I'll keep my patient if they are symptomatic. If they are sick, I'll consider otherwise.
We have, I think, 8 minutes. So I think we are ready to receive voice questions. Admin, please. Questions? If no question, I think we conclude. And before that, we have to thank Professor Saeed Al-Ghamdi for this very interesting lecture. And we hope that we will see you in further lectures, inshallah, about nephrology and about other topics. Thank you, everybody.
Thank you very much, Abu Muhammad. And thanks the audience. I really appreciate your attendance and your interaction. And thank you very much. Thank you.
Thank you, Dr. Saeed.